Let's learn how to read a knee MRI in 7 minutes. A knee MRI consists of axial, coronal, and sagittal sequences. Both fluid and fat-sensitive sequences are important. Our search pattern will include fluid, bones, cartilage, menisci, ligaments, extensor mechanism, and miscellaneous. For fluid, joint effusions are present between the suprapatellar and prefemoral fat pads. This is best seen on the sagittal view. Sometimes fluid can track down into the popliteal recess. A Baker's or popliteal cyst is located between the medial head of the gastrocnemius and the semimembranosus. Joint bodies can be present anywhere in the joint space, but pay close attention to the intercondylar notch. Lastly, look for small plica, particularly the medial plica, which could extend to the patellofemoral joint. Let's now move to bones and cartilage. Check the distal femur, proximal tibia, and proximal fibula. In particular, evaluate for marrow edema on fluid-sensitive sequences. In the setting of trauma, they can indicate contusions or fracture. Looking at fat-sensitive sequences, such as T1, are helpful to evaluate for T1 hypointense fracture lines. Suspicious lesions are often T1 hypointense as well, with loss of normal fatty marrow. For cartilage, look at 3 compartments: the medial tibiofemoral, lateral tibiofemoral, and patellofemoral. You can tell the medial tibiofemoral because the medial tibial plateau is shaped like a golf tee. Contrast this with the lateral tibial plateau, which looks like a golf club. Check the anterior, central, and particularly posterior weight-bearing surfaces for cartilage defects. For the patellofemoral compartment, evaluate the median patellar ridge, as well as the medial and lateral patellar facets. The lateral patellar facet is longer than the medial. Additionally, look at the femoral central trochlea. Next, evaluate the medial and lateral menisci. Each meniscus has 3 major components: the anterior horn, body, and posterior horn. There are also anterior and posterior roots. Look at the shape and morphology of the meniscus and evaluate for tears, which are defined as linear high signal extending to an articular surface and visible on at least 2 slices. The posterior horn is generally larger than the anterior horn for the medial meniscus, while they're relatively equal in size for the lateral meniscus. If there are significant meniscal volume loss, be concerned of a displaced meniscal flap, located within the intercondylar notch or meniscal gutter. Alternatively, this may reflect post-surgical changes. Next, let's evaluate the ligaments. The ACL and PCL are located midline. Evaluation in all 3 planes is important. The ACL extends from the distal femur and inserts in the central tibial plateau. The PCL also extends from the distal femur and inserts in the central tibial plateau, though posteriorly. Both the ACL and PCL have 2 bundles, which will be described in further videos. The MCL consists of deep and superficial fibers. The superficial MCL extends from the medial femoral condyle to the distal proximal tibia, 6 centimeters distal to the tibiofemoral joint line. The LCL extends from the lateral femoral condyle to the fibular head. Additionally, there are many posterior lateral corner structures, which are beyond the scope of this video. One important structure is the popliteus tendon, which inserts into the popliteus notch. The IT, or iliotibial band, is also important to look at. Fluid deep to the IT band may be seen with the IT band friction syndrome. For the extensor mechanism, look at the distal quadriceps, proximal patellar, and distal patellar tendons. Check for intact fibers as well as tendinosis. Evaluate patellar alignment on the sagittal view for patella baja or alta, with the caveat that a straightened knee position during MRI may alter these results. Patella baja or alta is better characterized on radiographs. If there is patellar lateral tilt or subluxation, consider measuring the TT-TG distance as well as qualitatively assess the trochlear depth for dysplasia. Check also the different fat pads for increased signal, the prefemoral, suprapatellar, and infrapatellar, aka Hoffa's fat pad. The superior lateral aspect of Hoffa's fat pad is particularly prone to increased signal, which can be seen with patellar maltracking. For miscellaneous, evaluate the neurovascular structures. For the popliteal artery, make sure that the anterior tibial artery does not have a high takeoff, which would manifest as passing between the popliteus muscle and proximal tibia. This would be helpful for surgeons during a surgery. Also make sure there is no perivascular edema around the popliteal vein, which would suggest a DVT. Next, look at the tibial nerve as well as the common peroneal nerve. If there is increased signal, this may indicate neuropathy. Look at the extensor muscle compartment of the partially visualized calf, which would indicate denervation changes as the peroneal nerve innervates these muscles. Next, look for the presence of aberrant insertion of the medial head of the gastrocnemius muscle, which may compress the vasculature and cause claudication symptoms. Next, check for any enlarged lymph nodes in the popliteal stations. Lastly, look for fluid in different areas, such as the semimembranosus bursa. Also look for pes anserine bursal fluid, which would be near the insertions of the gracilis sartorius and semitendinosus tendons at the medial proximal tibia. You now know how to read a knee MRI in less than 7 minutes. Please subscribe to learn how to read other MRI studies in the future.